Okay, so welcome back. So our topic for today is actually about, comparing long COVID and Lyme reactivation. I see this a lot. I think of all the latent infection, Lyme is like one of the latent infection that we see. Latent means there's a dormant state. There's a latency state. So if you think about it, the tuberculosis is one of them, syphilis is another one, and some of the herpes viruses, or a lot of the herpes viruses, are actually going into latency. But I want to focus on the Lyme disease or Lyme problem or reactivation of Lyme because since COVID and especially after the rollout of the COVID vaccine, then the reactivation of this infection, um, has been very common, very visible. And, for somebody like me who's testing this, because I'm presented with this patient who's very fatigued, having chronic symptoms. So let's discuss that. So it's specifically, comparing the long COVID and the reactivation of Lyme disease. Okay, so when you say reactivation, what does it really mean? So any infection that has latency or has a dormant state, that's the kind of infection that can be reactivated, and Lyme is one of them. And what's very peculiar or very unique about the Lyme is after the acute infection, it can actually avoid the immune system. It can make itself like incognito, no? So it avoids the attack or the what do you call this? It cannot be caught because it becomes almost invisible. For some reason, this infection has that special type of, is it equality or behavior, and it becomes very challenging because it becomes difficult to treat, because when you test it, then it's like there's no reaction, as if there's no infection. Okay, so just very briefly, this Lyme is actually caused by what do you call this? Is caused by the bacteria. It's a spiral bacteria. It's in the family of spirochete. It's the name of the most common cause of Lyme is called Borrelia burgdorferi. But there's so many other ones, but this is the most common one. And this is actually very similar to the infection syphilis, but don't worry, this is not syphilis, okay? But they are in the same family of spirochete. The difference is the syphilis is actually sexually transmitted, it's easily transmitted, whereas the Lyme or the Borrelia, uh, it's transmitted. There's a vector, or there is another organism, or not organism, but a tick, that transmit. The tick gets infected, and then the tick bites humans, and that's how you get infected. And there is a very, uh, what do you call this? It's like a classic rash, or when you see it, you will not make you will not be mistaken in saying that this is Lyme, because it's like a target lesion, and it's specifically called target lesion because it's like a rounded thing, and then with with a little papule in the middle of the erythema or the redness. So that is the rash. It's actually called erythema migrans. And, and once the human um, is bitten by a tick, and then that's when the bacteria or the spirochete is actually injected. The bacterium is injected into the human, into the skin, and then it goes into the blood, and then the infection begins. Okay, you become very symptomatic with that because it's flu-like symptom. You're gonna develop aches and pains. You're gonna have fever, and then it can also give you, palpitation, headaches, and things like that. And it's very important at this point that the person gets treated right away, because it can actually progress. It can go into a chronic state wherein the patient will actually develop a lot of complication. The three most common complication that it produces, number one, the most common is actually the joints, because it goes to the joint. So you have a lot of joint pain, especially the big joints like the knees. Both knees are affected. Neurologic sign and symptom, you can have headaches, and you can have, cognitive dysfunction. You can have neuropathy. You have tingling and pain, nerve pains, and you can even have the Bell's palsy, wherein you have half of your face is actually paralyzed. And then you can have it can affect the heart. Get palpitation and you know. Myocarditis possible, or pericarditis, but the palpitation is the most common symptom or manifestation. And the electrical wiring of the heart is affected. And those are the three most commonly affected: the musculoskeletal, your joints, neurologic, and the other one is the cardiovascular. So, what happens when you get the COVID and you progress into the long COVID? The signs and symptoms of the long COVID are actually very similar to the Lyme. So, if and the COVID, or specifically spike protein, that's my assumption, is the spike protein is actually capable of reactivating the infection itself. And the other mechanism is in COVID, since the target of the COVID is actually your lymphocytes, specifically the CD3 and the CD8, but the CD4 is also affected. So the surveillance mechanism, when you get lymphopenia, or the decline in your CD8 population, that's the one that's responsible for actually, making sure that any infection that's around, they are either put back to sleep or they are terminated. And so the CD8 is responsible for keeping this kind of infection at bay. But if after the COVID infection or injection, long vaccine, long COVID, it will lose the surveillance mechanism that is exactly the function of your CD8. And so this latent infection are gonna come out. They're gonna be reactivated, so to speak. In other words, those infection that are supposed to be sleeping, suddenly they're all awake, and that's because of the COVID. But so to me, it's like two mechanisms: the spike protein, which is capable of actually reactivating the sleeping infection, and number two is the deficiency of the CD8 or lymphocyte, CD8 lymphocyte. Okay, so that's the one, to me, triggers the reactivation of this infection. So in the beginning, this is just my observation again with my population, with the senior population. You know, the very first year, we have data from 2021, January until December of 25. The longer, or as time passes, if it did not reactivate the first year, the second year, more people, the third year, more people, the fourth year, more people, and the fifth year, more people are having the reactivation of this infection. And again, it goes with my findings that the CD8 is actually going down, CD3 is going down. That's a T lymphocyte count. And so the infection gets reactivated. And I'm not going to discuss the other latent infection that are getting reactivated probably some other time, but when the Lyme is getting reactivated, other infection are also doing the same, okay? So as I said, the common sign and symptom, neurologic and cardiovascular and musculoskeletal. To repeat, the neurologic, you're going to have, it's almost acute symptom again without the rash, okay? Because the uh, the bacterium or the infection is already in your body, and so there's not going to be a rash, just the sign and symptom. Are you going to have fever? No, you don't develop fever. So you develop the joint pains, you develop the cognitive dysfunction. There's a cognitive decline. There is memory issue, and you get all the neuropathy, tingling and pain and numbness, whether it's in the extremities or in your face. And then the cardiovascular, which is the common presentation in the heart, is like palpitation or rhythm disorder. Okay, so it's very similar to the long COVID or long vaccine presentation. And so if you do not have the blood test that this patient actually has COVID and at the same time reactivation, then you're going to miss treating both diseases, right? So you need to, the doctors, if there are doctors listening to me right now, you need to do the blood testing. And what I use here in Florida, I use Quest Laboratory, and basically they have the screening for Lyme, and they have the actual IgG bands. We usually have, I believe it's 18 or 23. For the person to be considered having reactivation, you should have at least 4 or 5. 5, definitely that patient has reactivation, and you better treat that patient because you don't know where it's going to go. If it goes neurologically and it goes to the brain, then you're going to have a very big problem. If it goes to the heart, that's also a big problem. When it goes to the joints first, then you have a little bit of luxury of time, and the patient complains because it's very painful, and they have swollen knee, and they really can't walk because it's a crippling pain that you develop in the joints. And so you have uh, a little bit of luxury, but all these signs and symptoms are actually presenting almost simultaneously. When you have the blood test, you're going to see that it is long COVID. And for those people who don't know how to work up the long COVID or long vaccine, in the future, I will present it, what test to order. I'm going to design it in such a way that the doctors who are listening can actually learn how to work them up. So my workup for a long COVID, long vaccine, Lyme testing is one of them. And so uh, that's what you have to do, because when you rely on symptoms, obviously you can have a high degree of suspicion, clinical suspicion, and you can even treat them, empirically, meaning you don't know, you're not 100% sure that if it is Lyme reactivation, but very highly suggestive of it. There's no harm, treating the patient with antibiotics. Just make sure that the patient is actually not allergic to the drug of choice. The drug of choice of treating Lyme is, what do you call this? Is doxycycline. And one thing also, what is very common with this, which I also see in COVID, long vaccine, is that when the Lyme is reactivated, the autoimmune also come out. It's alive. I always see the pattern that they come out together. So the spike protein will cause you to have the autoimmune, and it's going to get aggravated by your Lyme. Before COVID era, um, you already have the big association between Lyme and autoimmune. And so both COVID and Lyme can cause autoimmune. So if you put them together, you can imagine how miserable the patient who's having long COVID or long vaccine. So I just want to point that out. But the goal is to treat the patient as soon as possible. Fortunately, when you treat the drug of choice for me for the long with the autoimmune induced autoimmune or no auto COVID induced autoimmune is actually hydroxychloroquine. And guess what? Hydroxychloroquine is a third line agent for treatment of Lyme. So if you're treating the patient for the Lyme with doxycycline, and I add another one actually, if I give them oral, I give them cefuroxime or Rocephin IV, ceftriaxone. And then, so I put them together. It depends on how many bands or how many IgG bands are turning positive. But a reactivation of the Lyme involves IgM bands. Those are the acute antibody. It's actually telling you that there is a reactivation or acute Lyme. And but the other way to identify that there is reactivation, you're gonna have IgGs, which is the durable antibody, but you have to have 4 or 5 of them. Like today, I actually saw a patient. She's a female patient. She's in early 60s. She had the infection or COVID infection back in 2021. And right now she has all the symptoms. She's very fatigued. She has brain fog. She has joint pains, but not the knees. It's just all over the body. And then she has uh, well, she's not she can she has difficulty losing weight. And then what else? But the most significant sign and symptom or symptom for her um, are actually the fatigue and the brain fog. And so when I open or discuss the result of her laboratory, she has very high spike protein antibody. The Lyme, she had like eight uh, strands or 8 bands of IgG. So it's an obvious reactivation. And I think she got reactivated way before, and because she's been suffering since 2021. And she's surviving, but very symptomatic and very miserable. So she came to me, and one advantage or one good thing that she did is she tried to be in a very healthy diet, remove the all the processed food. So it helped the inflammation. And so I saw her today, but one thing is because she's got so many bands, and it's very very uncomfortable knowing that this patient has a fully reactivated Lyme, and I need to do something. There are type of there are situation we're in. You have to actually use three agents or three antibiotics for for some patient, and this patient is one of them. She's very symptomatic. She's got so many bands, full reactivation. So I use three antibiotics. And what are they? I use ceftriaxone, oral doxycycline, and the other one that we also had is daptomycin. I think there's a recent report that if you use those three antibiotic, then it's likely you will likely be successful in actually controlling the infection and eliminating the infection. That's what we're gonna do. I already started her today, and then let's see what's gonna happen. And then I also treated her for the long COVID because she hasn't been treated. So I put her on a spike detox protocol, and so I gave her the ivermectin and the four NAC no nattokinase, NAC bromelain quercetin complex, and the curcumin. And I also treated her for autoimmune. She had four autoimmune diseases, and you know what they are? She has rheumatoid, she has possibility of lupus, she has APS. Can you believe that? APS, and she has autoimmune hepatitis. And it's bad. It's a bad situation for that lady, and she's unvaxxed. She was actually infected, as I said, in 2020 or 2021. So that was my case today. Very interesting. And then why is this very important? I think for the doctors, as I said, who are watching, you really need to work the patient up when you are presented with this kind of patient. And so, what do you call this? This patient, in terms of the the T lymphocytes, she actually didn't have deficiency of the CD8, but it's trying to be deficient, but she has a deficiency of CD19. And what is that? It's a B lymphocyte. It's a B lymphocyte. So I expect this patient to become deficient on IgGs, but well, I'll give you a good example on that in the future. So for the doctors, please, it's time for you to wake up. These are the very complicated, um, diseases that you encounter when we are dealing with a COVID, long COVID, and long vaccine. So you will see in terms of the key differences. Hmm. The key difference is it's very difficult without the blood test. And so when you it's more of an overlap rather than differences, okay? So you have to really, I cannot overemphasize it, you need to test, to do a blood test, a workup. So, what do you do for the testing? You can order the Lyme there is a profile or specifically a blood test for the Lyme, and there is a screening, and there is actually like you're testing the IgG, the bands of antibodies specifically against the Lyme. I use the Quest here, which is one of the biggest reference lab here in Florida, but you can also use other labs. Actually, some people or some doctors who are actually specialists on in this field, they use other labs, and they're different names, and they're not in the mainstream, but they're supposed to be very good. I cannot give you the names right now, but I will see if I can give them. But if you search, you can find them. So, uh, and obviously you have to do the the basic blood test. But again, as I said, for us to differentiate the two, the blood test will differentiate uh, the two condition, because they have more of common symptoms or overlaps rather than differences. So it's the blood test that will break the deal. Okay, so um, practical advice to for the viewers: if you are having sign and symptom, joint pains, and even muscle aches and pains, abnormal fatigue, or even if it's not very bad or kind of mild fatigue, or it comes and goes, you have on and off headaches, on and off palpitation, I advise you. But actually, the key is if you're vaccinated or you had COVID before, okay? Because that is the major factor or the major denominator that I see right now in the reactivation of Lyme. History of COVID infection and history of vaccination, or both. Okay. And so ask for help right away, because if the neurologic um, what do you call this, complication of Lyme, sets in and it's bad, then there might be, it's going to be very hard to recover, and there might even be permanent damage. So I think that's what I have to say for now, and I'll let you know, or probably next time I'll even bring some samples of the actual test so that you can see, and we'll uh, we'll show it to you. And this is it. And thank you very much. Thank you for joining me, and thank you for listening or watching. Okay. Bye-bye. Bye.